Get going. Hi, I'm Jeremy Sugarman. I'm one of the co-principal investigators of the Mores grant at the University of Malaya. Welcome to the Hot Topics in Research Ethics webinar series. I'm going to turn it over first to my colleague Nisha, who's going to just say a few things about the program before we start the actual program.
So good morning and good evening for everyone joining us. So first of all, this is the link for you to join or listen to all the previous recordings of our hot topic.
Nisha, you're on mute.
Yes, sorry about that. So I'm going to talk to you about the Masters of Health Research Ethics program that we have in the University of Malaya Faculty of Medicine. You all probably know, some of you, is actually supported by the Fogati International Center, National Institute of Health, US Bioethics Training Grant. And what you see here is our very first batch. Very proud and here. Slides are not moving. Right, so it's a 1-year full-time program that we have. Every year we have the intake in either September or October. This year is going to be in October. Application is actually open right now, and the admission is end of August this year, 31st of August. What's beautiful about Mores is it's very unique here in the region of the Southeast Asia. It aims to produce the graduates with the knowledge and skills necessary to engage in the field of research ethics, health research ethics specifically. So it's also very great about this is that the strength that we have is the collaboration between the Faculty of Medicine, University of Malaya, and the Berman Institute of Bioethics, Johns Hopkins University. As I said, is supported by the US NIH grant. And for that, we actually have the privilege of offering scholarship for selected applicants from the low and middle income countries within the Southeast Asian region. So for more information, please log on to the website and also in the chat group or the chat function, we will share some of the information about the program. So we hope to see some of you interested in applying. Right, over to you, Jeremy.
Great, thanks. You can do the next slide. Great. Well, it's my great pleasure to introduce today's webinar speaker, Professor Annie Lyerly from the University of North Carolina. Dr. Lyerly received her undergraduate education at Dartmouth College and then her MD from Duke University and a master's in philosophy applied ethics at Georgetown University. We met a while ago when she was doing her medical training at Duke, and I was lucky enough to be able to work with her early on sort of nurturing her interests in bioethics, and she's exceeded every expectation, becoming sort of a major luminary globally on research with people who can become pregnant. And she's rightly a professor at the rival to Duke University, UNC Department of Social Medicine. She's been there since 2016, and she's an obstetrician gynecologist. And you can see her other affiliations there. Her work is broad and long, but she really is known especially for the work she does around any of the issues that are related to people who can become pregnant and women in research. So we're delighted that she's with us today to be able to tell us some of the greatest and latest information on this topic. Before I turn it over to her, go to the next slide, please, Nisha. We'd like you to do this during her talk. She's going to go for about 30 minutes or a little bit longer. But in the meantime, please type your questions as you think of them in the question and answer box or the chat box. The moderators are going to try to address them during the discussion. The session is being recorded and made available at the link that Nisha provided at the beginning. And if you need that link, just contact us and we'll get that for you. Next slide. And at the end of the survey, at the end of the seminar, when you leave, there'll be a quick exit survey that opens immediately. If you do us a great favor and complete that, it'll help us bring to you webinars that are of interest to you and importance, and we love your feedback. So without any further ado, I'm going to turn it over to Professor Lyerly.
Well, thank you so much, Jeremy. It is a real honor to be here, and I'm just delighted to have the opportunity to share some of my work, which has spanned more years than I want to admit on this topic, especially with this group. So I'm going to start by sharing my screen here. I think this is the right one. Okay. Nope, that's not the right one. Sorry. I think, nope, that's right. Yep, that's correct. Okay, sorry about that. But you're getting a preview because we want to start at the beginning. Okay, here we go. So the title of my talk is Ethics and Research in Pregnancy, a Shifting Paradigm. And as I said, this is a topic that I've worked on for, I would say, close to 2 decades. And a shifting paradigm has been the goal for a long, long time. So the fact that I can talk about a paradigm shift in this area today is exciting to me. So I wanted to start a little bit from the beginning, which was when I was developing as and in my early years of practicing OBGYN. I found it very puzzling and really frustrating that, in contrast to many areas of medicine, the evidence base for treating pregnant people who faced illness was very poor. There was sort of acceptance that that is the way it is, and a blaming really of ethics for it being that way. Among the residents and the attendings, they said ethics is the reason that we don't have the data that we need. So I was lucky enough to do a fellowship in bioethics at Johns Hopkins starting in the late 1990s. And what I learned there was something very different, which was that ethics requires inclusion of people who are going to use and benefit the medications or the interventions that are being tested. Ethics requires that the research endeavors serve the population. And so I really got the sense that ethics was not really the reason we couldn't do research. Maybe it was part of the reason, but there was definitely an ethical argument for why we must do that. So I started on a journey to start making that argument. So the journey began with something called the Second Wave Initiative. It was a collaborative that I started with Ruth Faden at Johns Hopkins and Maggie Little at Georgetown University. And it was really, in the beginning, an effort to argue that ethics requires inclusion of pregnant people and their interests in research, that we can no longer blame ethics as the reason that we must exclude them, and that the status quo is really a problem. We made a 3 or 4 pronged argument about why, and I'll share that with you in a bit. But as folks started to accept the idea that research can and should be done with pregnant people, then the question was how. If we must do it, how do we do it ethically? So I have received grants from the NIH and from the Wellcome Trust to do projects to help develop ethics guidance for the inclusion of pregnant people in HIV research. That's the Phases Project. For pregnant adolescents in HIV research, that's the Prepare Project, and that's ongoing. And then in pandemic contexts and vaccine research, that's the Prevent Project. And so Phases and Prevent actually have guidance out there that is on the web, and I can point you in the direction of it toward the end of the discussion. So now I'm going to tell you a little bit more about the substance of this effort and the the um, the the paradigm shift that I think is happening right now. So as an overview of my talk, I'm going to talk about the history of exclusion of pregnant people and people who can become pregnant from biomedical research. I'll talk about the evidence gaps and the consequences of the evidence gaps for the health of pregnant people and the health of their offspring. Some of the barriers to research during pregnancy, many of which will be well known to people on this call or intuitive. Some of the ethical considerations that our group has articulated that support research in the context of pregnancy, some ongoing challenges, and especially some new opportunities and guidances that are out there that are starting to be sort of published by the month and that are very, very exciting to have access to. So the history of exclusion. So why do we call the initiative that argued for inclusion of pregnant people in research the second wave? Well, because there was a first wave. So the first wave is reflective of the fact that in the early 1990s, women and their health interests were underrepresented in research. So for diseases that affected both women and men, women tended to be excluded from those studies sometimes because of their capacity for pregnancy, sometimes for other reasons that we can talk about, like the differences in their physiology, which were at one time understood to be additional complexities that would complicate the data, but which are now seen to be reasons that they should be represented. So in 1993, the United States government passed something called the Revitalization Act, recognizing that certain groups were underrepresented in research. The act required that both women and minorities be fairly represented in research, and that any study that excludes women or minorities from research had to do so for reasons other than cost, like women don't get this particular disease, say prostate cancer. So women are now a majority of research participants, although gaps remain in many areas. So unfortunately, pregnant people and their health interests were left behind. So despite the fact that many of the folks that pressed forward the first wave argued for the inclusion of pregnant people in biomedical research, that part of the recommendation was basically ignored. The result has been a dearth of information to guide care. So if somebody who is pregnant presents to a doctor and they have rheumatoid arthritis or asthma, or they're having a heart attack, there are really not excellent data to tell physicians whether the treatment that they would usually use if this person were not pregnant is safe, or whether it will work in the same way. So the second wave initiative said, look, this is an unethical state of affairs, and ethics requires that pregnant people and their interests be represented in biomedical research. So why is it so important that pregnant people be included? I mean, a lot of folks had said, if we are doing a study with an investigational drug, if we are trying to learn something, why don't we learn that in a population that is not pregnant and then just apply what we learn to pregnant people in the clinical setting? And the reason is doing that way results in gaps in pregnancy-specific evidence. They include gaps in the dosing that reflects the physiologic changes of pregnancy, which are significant, that reflects gaps in our knowledge about fetal safety, that establishes the likelihood, for instance, of birth defects or longer-term impacts of taking a medication in pregnancy or not taking a medication in pregnancy. Maternal outcomes that predict the impact of treatment on maternal health. So decisions about treating or not treating disease in pregnancy may have impacts on pregnancy, birth, and longer-term outcomes. And finally, efficacy. So especially for drugs with what we call obstetrical indications, like drugs used to prevent preterm birth or treat preeclampsia, we actually don't know very well about how those medications work based on evidence from clinical trials. We feel like we have some knowledge based on our long-term clinical practice, but there are lots of problems with that. So what are the harms of these evidence gaps? Well, the overarching harm is that the risks that are avoided in the research context. So we think, okay, the best way to avoid pregnancy-specific risk with the use of a drug is not to do research with that drug, and you don't have any risks in the research setting. But those risks, of course, do not disappear. They just shift to clinical settings where they grow. Because the fact is that pregnant people do take medications. Pregnancy is not a magic bullet against medical illness. So drugs are used, the risks expand, and we don't capture the kind of data that we need to make better decisions down the road. So when the risks shift, there are several harms that result, and I'm going to quickly go through the key ones that I consider most important, but there are other ways to articulate these. So the first harm is ineffective treatment. So what we know is that pregnant bodies are different. They're not just shaped differently, but they're physiologically different. So there are physiologic changes in cardiovascular functionality. For instance, the total blood volume increases by 50%. So you have 150% as much blood when you're pregnant than when you're not pregnant. Gastrointestinal processing changes. There are changes in renal clearance, and there are changes in enzymes, many of which are the enzymes that metabolize drugs. So because of these changes, pregnancy can dramatically affect how the body interacts with drugs, pharmacokinetics or PK. So what this means is that when you give a pregnant person a normal adult dose of a drug, it might be inappropriate for the pregnant person. I mean, oftentimes that dose is too low, and so they are left untreated and exposed to the harms of untreated disease, whether that is the harm of a breakthrough in seizure control or exposure to an infectious disease. The dosing may be too low, or sometimes the dosing, may be too high, leading to excess toxicity for pregnant people. So it's actually not absolutely predictable which way these things are going, but when pharmacokinetic studies are done, oftentimes we find out the dose that we've been given is the wrong one, been giving to pregnant people is the wrong one. A classic example of this is in the HIV space with the drug called cobicistat. So many of you may know that cobicistat is an HIV booster drug. It's given along with antiretroviral therapy to boost its power. It was approved in 2012 and was used in pregnancy very soon after approval. In 2018, some devoted groups of pharmacokinetic researchers measured the doses of cobicistat and the drugs it boosted in pregnant people who were taking it. They measured this opportunistically. So people who had already decided to take the drug, they measured drug levels, and they found that it had reduced concentrations of both cobicistat, the booster drug, and the drug it boosts, raising concerns about viral breakthrough, resistance, and vertical transmission, maternal to child transmission. So what this means is that pregnant people were taking this drug for 6 years at the wrong dose. So the United States Food and Drug Administration now recommends against the use of cobicistat in pregnancy because the correct dose has not been identified. And whether that's the right response to this is a question for another day, but it's just one of many examples of figuring out after many years that we were giving pregnant people the wrong dose. A second harm is the one that really is first and foremost in the minds of many clinicians, is inappropriate risk. So the worry is that the drugs that pregnant people use that they are prescribed, that they need, have a risk of harm. One of the surprising facts is that the teratogenic risk, so the risk of birth defects of medications, is undetermined for more than 90% of drugs on the market. When drugs are approved on the market in the United States, usually all we have are animal data, and that is not sufficient to determine teratogenic risk. So what this means is that prescribed medications may be unsafe for the fetus. And moreover, given the gaps on maternal outcomes, so even when we know that a medication that we think has been out there for a long time is safe for the fetus, it may carry an appropriate risk for the pregnant person, which we have also seen pretty vividly in the HIV space. It's hard to talk about birth defects without talking about the thalidomide disaster, because this is really what is first and foremost in the minds of researchers and doctors and many patients. So thalidomide was a drug developed for treatment of morning sickness in the 1950s. And at this time, it was really thought that the placenta was a kind of a barrier between the pregnant person and the fetus. Thalidomide was approved for use in more than 20 countries. For instance, Canada, Europe, and Australia. By 1962, however, the drug was linked to very severe birth defects, which were limb reduction abnormalities, where usually where the legs and arms did not develop properly. It affected more than 10,000 pregnancies worldwide. But the story in the United States is kind of an interesting one, because approval of thalidomide was blocked in the US by a pharmacologist and physician newly minted at the United States Food and Drug Administration named Francis Kelsey, who said, "I don't think that we have enough research to approve this drug in pregnancy." So the result was that in the US, there was a quick response, and the US government was empowered to regulate the testing and approval of drugs in a much more empowered way because of the thalidomide disaster. However, the response to pregnant people, instead of regulating or requiring research in pregnancy, was to exclude them from research, to make the bar for their inclusion very, very high, essentially meaning that the circumstances of thalidomide were set in stone. Inadequate research was the cause of the thalidomide disaster, and we still have inadequate research. So a colleague and I, Miranda Wagner, wanted to understand, did Francis Kelsey, who really prevented the thalidomide disaster, want the exclusion of pregnant people from biomedical research? Was that sort of the lesson that she would have taken from what she did? And it turns out that the answer is no. She had said that thalidomide should have been recognized in a well-controlled clinical study involving comparatively few patients in pregnancy. And she endorsed the fact that the conduct of clinical trials in pregnant women present special problems, but are necessary to assure that safe and effective drugs will be available for their use. So just to say, if thalidomide is offered as a reason that pregnant people are excluded from research, it is a reason. It is a reason that the research community pauses and often refuses to include pregnant people in biomedical research, but it's not a good reason because it is the same circumstances that led to the disaster in the first place. So it was a paradoxical response. So the third harm is something we call reticence. And I think this could be the most impactful harm of exclusion. So basically, fetal safety concerns make policymakers and doctors reticent to recommend and women reticent to use medications and vaccines in pregnancy because they haven't been tested well. And the fact is that the failure to treat may harm both the pregnant person and the fetus. When we think about teratogens, we usually think about drugs like thalidomide, but there are other kinds of teratogens. Infectious diseases are teratogens. Endocrinologic diseases like diabetes are teratogens. So there's lots of kinds of teratogens. And the failure to treat a disease or keep a pregnant person healthy also can lead to the same kinds of harms that taking a drug might. So what we know is that failure to treat may harm both pregnant person and fetus, and harms of undertreatment may often outweigh the risks of medication use. And it turns out there's lots of examples of this, but I think COVID is the most recent and powerful example. So as you all may almost certainly remember, pregnant persons were excluded from the COVID-19 vaccine trials and also from the therapeutic trials that led to the authorization of the mRNA vaccine in December 2020. So the problem was that, many people who were at risk for COVID were women and individuals of childbearing age or pregnant people. And in many cases, these were folks that were working in high-risk circumstances. They were teachers, they were healthcare providers, and we were starting to learn that pregnancy had worsened the outcomes of COVID. So what is a pregnant person to do for whom there is no data on the vaccine, but they are high risk? So here's what they were told by various organizations. The Centers for Disease Control in the United States said, vaccines are unlikely to pose a specific risk to people who are pregnant. Vaccination is a personal choice for them. So vaccination in most cases is a personal choice. So, in many ways, when we see this language of personal choice, it is a way that some of these organizations shift responsibility away from themselves and into clinical settings. But pregnant people need guidance and they need support. They don't need responsibility here. The World Health Organization started with a really problematic recommendation. They said pregnant people, the World Health Organization recommends not to use vaccines in pregnant women unless the benefit outweighs the potential vaccine risks. Well, we hadn't articulated any vaccine risks. The mRNA vaccines were not the kind of vaccines that we worry about in pregnancy. And even though there were some mild fevers associated with vaccination, these fevers could be treated with antipyretics. So this wasn't the kind of vaccine that we would never give a pregnant person. So it was hard for people to understand what the WHO was saying. And it seemed like they knew something that, that they weren't sharing. In the United States, some of the professional organizations for OBGYNs thought, this doesn't look good. We have seen medications and vaccines that have not been tested that would be of benefit withheld from pregnant people because of fear. And so they tried to get on that quickly and said the authorized vaccines should not be withheld from pregnant women who choose to receive them. This actually was happening across the US and indeed across the world. And in response to some excellent reporting, the World Health Organization revised their guidance to say, and they said this is not a difference in guidance, it was a difference in wording, that pregnant women at high risk of exposure or who have comorbidities may be vaccinated in consultation with their healthcare provider. Again, kind of a talk to your doctor or it's a personal choice kind of thing. So still not a fulsome taking of responsibility around the risks and the uncertainties. So what happened? Reticence. So this is a setup for reticence. So what we found was that over time, pregnant people either did not want to get vaccinated or healthcare providers did not want to vaccinate. This was, again, US data that showed that by September, many of us who were not pregnant had raced for the vaccine, but there was only 31% of pregnant people were vaccinated, even as they were a high-risk population. And when we looked across races and ethnicities, the numbers were much more stark, with Black individuals having a 16% vaccination rate. And it wasn't really until the Centers for Disease Control took a stronger stance that the rates started to trend up, but they trended up pretty slowly because that reticence had set in. Another problem is that with these kind of reticent global health guidance, these reticent guidelines, there emerged disparities in global health guidance for whether pregnant people should be vaccinated. And sort of what we saw was that in the low and middle income countries, there was more caution around use of vaccines. And in these countries, the authorities cited the absence of data as a reason not to recommend the vaccine. And then as their policies evolved, they cited observational data as a reason for shifting policies. So basically, not doing research increased disparities in these populations. Okay, if that wasn't enough, there's another harm which pertains to a particular kind of data gap that surrounds therapeutics for pregnancy-specific indications. Again, here I'm talking about preterm labor or preeclampsia. So sometimes a lack of data pushes in the opposite direction. And when it does, it's usually around these pregnancy-specific interventions that have to do with control of pregnancy and birth. So what we know is that intervention around birth, as opposed to use of medication and treatment for pregnancy-related illness, has been routinized, expected, and sometimes it is forced. So certain, and as I mentioned before, certain therapeutic outcomes occur only in pregnancy. So if you don't study drugs in pregnancy, you're not going to know whether drugs are useful for these therapeutic outcomes. Turns out that only 9 drugs have ever been approved for obstetrical indications, and there's no approved treatments for many common conditions like preterm birth. The current treatments that are in effect may in fact be harmful and create a sense of, false hope or false reassurance. And this is a terrible position for women and doctors to be in when there is nothing to be done. So just to summarize where we've come so far, without adequate evidence, pregnant persons may be given the drugs at the wrong dose. They may be given drugs at unacceptable risk. They may be denied access to beneficial drugs, and they may receive ineffective obstetrical interventions. And then there's one more harm. So exclusion from beneficial trials. So some clinical trials offer the prospect of direct benefit. Pregnancy can be a barrier to accessing such benefits, and it's particularly harmful where the treatment options are limited or the condition is life-threatening. So exclusion leaves pregnant women and their offspring exposed to life-threatening illness. The classic example of this is Ebola, obviously a life-threatening infection with a very high mortality rate in pregnancy. 89 to 93% of mothers with Ebola succumb to it, and nearly 100% of fetuses. In an epidemic in 2013 to 2016, pregnancy exclusions existed for all drug and vaccine trials. And reflecting on that exclusion, a group of researchers and advocates and bioethicists argued that pregnant people were protected to death. So given, I would hope this is a pretty strong argument for including pregnant people in biomedical research. So what's taken so long? I mean, I've been making this argument for almost 20 years. Others have been making it for longer. Why are we not doing the research? And there are many reasons that we have learned about over the years. One is myths and misconceptions about what research regulations allow. One is problems with the drug development and approval pathway, which doesn't incentivize studies of drugs in pregnancy. Another is risk reasoning, especially reasoning that tries to eliminate fetal risk rather than sort of manage it and balance it across benefits to the fetus and risks and benefits to the pregnant person. That sort of protectionism that pregnant people must be protected from the risks of biomedical research, but kind of ignoring protecting them in the clinical space through the generation of data. Lack of training and experience of researchers, of IRB members, et cetera, legal and logistical challenges, something we call justificatory asymmetry, which is really that you have to really do a lot to justify the inclusion of a pregnant person in biomedical research, but you really don't have to do anything if you want to exclude her. So these are some of the reasons. But as I said, I think there is a paradigm shift. There were several reports issued in the late 2010s. The FDA issued draft guidance for industry in 2018. It's still draft guidance, so this is still not been finalized, but they said that filling the knowledge gaps regarding safe and effective use of drugs is a critical public health need. And there was a task force that advised the Department of Health and Human Services, which is called the PregLac Task Force. They have a 400-page report that I'd encourage anybody to read who's interested. And they said that a cultural shift is necessary to emphasize the importance of doing this research. And, I really do think when logic doesn't work, there's something deeply at play with culture. So, but, happily, I think there is evidence of shifts, at least in the research culture. And there's sort of three ways of thinking and talking about research that have evolved over the last 10 or so years that I think reflect that shift very vividly. So one is the shift from thinking about pregnant people as a vulnerable population to thinking about them as a complex population. So for many, many years, for decades, pregnant people were grouped alongside children, prisoners, individuals with intellectual disabilities as a vulnerable population for whom additional research protections needed to be upheld. But it turns out, pregnant people are different from all those other populations because their capacity for autonomous decision, their capacity for consent there's nothing about pregnancy that constrains that. And so instead of being a vulnerable population, they are now considered a complex population, and they have been removed from the list of individuals considered vulnerable, both by the World Health Organization, SIOMS, and by the regulations governing U.S. research. Second is the idea that pregnant people need to be protected from research. That is the paradigm that emerged after thalidomide. And now there is a really broad understanding that the best way to protect pregnant people writ large is through research. So from moving protection from research to protecting them through research. And then the third is really a question about what justice requires. So the idea is that justice used to really be focused on not overburdening certain populations. And so the idea was that it should be okay to exclude pregnant people from research because that's a way to make sure that they weren't overburdened. And that was a way to ensure justice. And now we know that we've landed in a very unethical state of affairs, a very unfair state of affairs. So the requirement, instead of presuming exclusion and moving on, is to ask the question, is it fair to exclude pregnant people from this study? Do we need these data for pregnant people? Are they likely to benefit from participation? So our group articulated 3 ethical foundations that support research in pregnancy, and I know we're kind of getting toward the end, and I probably have maybe 3 or 4 more minutes, and then I'll open it up for questions. So one of the ethical foundations is protection. So the idea here is that pregnant people deserve protection from intervention-related risks. So one of the animating missions of biomedical research is to conduct studies in controlled circumstances so that when drugs are used by the general population, they can feel assured that they are safe, that they've been tested. So pregnant people do not enjoy that kind of protection. Access to the benefits of new technologies is the second ethical foundation. So everybody should get access, fair access to the benefits of new technologies. But when you don't have data about those new technologies, often you are required to use older drugs. We see this in pregnancy a lot. Some of the oldest, for instance, antihypertensive drugs that you'd never use on a non-pregnant person are used in pregnancy because we have knowledge about those drugs, but we have less knowledge about the newer drugs. So pregnant people don't have access to the newer drugs. And then finally, the third ethical foundation is respect for pregnant people's own health. So when we do research in pregnancy, oftentimes it's around protecting the fetus from risks that can be transmitted through the pregnant person's body. And research is required with pregnant people to ensure that their health is also served. So I want to just highlight a few resources, and then I see Jeremy's face, and I'll open it up for questions. So one of the resources is the product of our phases work that was developing guidance for the inclusion of pregnant people in HIV and co-infections research. We have a downloadable 80-page, not that, and big font guidance. This was the product of a 26-member working group and lots of empirical research. And it does some of the tenets apply beyond the HIV context. There's our recommendations there. I encourage you to read it. WHO has just come out with a toolkit for conducting research in pregnancy, and there is a big section on ethics that I have been involved in developing. It's still being polished, but it's up on the web. So it has wonderful resources for those who want to conduct research. There's a lot of efforts to involve the advocacy and civil society in developing guidance for research in pregnancy. AVAC has had a wonderful think tank and a report from that. And this Bridge Commission has guidance for women who suffer from chronic disease. Last of all, the National Academies just issued a report that reflected on the worry that there is liability associated with doing research in pregnancy, and that is really the dominant barrier. And this report found that there have been no reported legal cases involving liability related to a pregnant woman's participation in a clinical study since 1963. So people might be afraid of liability, but it has not come to fruition. So perceptions of liability exceed any actual liability. Again, a great report. I encourage you to read it. And then I'm going to just quickly go, we can maybe talk about some of the new opportunities later. In summary, the exclusion of pregnant people from research has resulted in harms. Research with pregnant people is now recognized as an ethical imperative. Pregnant people represent a complex population in need of research. They deserve a fair share of the benefits in research, protection, access, and respect. And there are a growing number of resources, busting of myths, and a paradigm shift, which offer promise for eliminating evidence gaps for care during pregnancy. So again, I'd like to reiterate our sort of our mantra: protect pregnant people through research, not from it. So thanks everybody for listening, and I'm happy to take about 10 minutes of questions.
Great. Annie, thanks so much. That was stunning. It was just such a great body of work. And I think for people who haven't been following it over time, it really gives the long view with progress being made, which is really exciting in ethics. So this is great. We actually have some nice questions in the Q&A function. So let me just call them out, and then you can have at them. The first question we have is that in studies involving pregnant women, is there an ethical obligation to obtain consent from the father? And if so, under what circumstances?
Yeah, this is a great question, and it's one that often comes up. I think there are, first I'll say sort of foundationally, ethically, I think there are very strong arguments that indicate that there is not an ethical obligation to obtain consent of the father. I think there is an ethical obligation to support pregnant people in their efforts to involve family members, including their partners, in their decision making. But given that the research is on their body and they are autonomous individuals, the consent of a third party is in general not justified. So this has been a subject, and I've given a 30-minute talk on this, so I won't go into the reasons. But with regard to the guidelines, the US federal guidelines have a subpart on pregnancy called Subpart B. And Subpart B was revised around 2000. And at that time, there was a requirement for consent of the father in some studies. And it was resulting in problems recruiting pregnant people to participate in research that would be of benefit to them and their babies, specifically in the HIV context. So those recommendations were revised to not have any consent of the father, but they were revised again when a different president of the United States was elected. And so the current regulations basically say that the pregnant person's consent is sufficient in all circumstances, except where the prospect of direct benefit from participation in the research is to the fetus only, so that there's no prospect of direct benefit to the woman, only a prospect of direct benefit to the fetus. This is a really rare circumstance because, as you know, the pregnant person and the fetus are connected to each other, and oftentimes what benefits one benefits the other. But this is the stipulation in US regulations. SIOMS says no, the consent of the father is not required. There are ongoing conversations in Europe about this that I have heard about recently that, again, I think are a topic for another day, but it's an excellent question, and I think an ongoing source of confusion. But I think just remember, pregnant people are autonomous, and they're making decisions about their own bodies. So the notion that consent of a third party for them to participate or not would require a high bar, which I don't think is met in most, if not all, circumstances.
Awesome. So Adiba wants to chime in with a question or comment, and then we also have two other questions in the Q&A box. So we'll turn it to Adiba first, and then maybe what I'll do is after you respond to her, I'll ask you the last two questions, and then we can wrap up in the last 7 or so minutes. Adiba.
Yeah, thanks, Jeremy. For some reason, I couldn't type in the Q&A box. Annie, that was fantastic. That I learned a lot. But I could also sense your frustration that it's taken you so long to get, the fraternity to this point, which made me wonder: has it got to do with the fact that it's a gender thing, a woman thing, and the paternalistic nature of medicine in general, that it's taken you and others working in this field this long to come to this point?
My short answer is yes. I mean, I think for most things related to pregnancy and related to pregnancy and ethics, there's a question of gender. The force of gender is there if you look for it. I think particularly here, what we're seeing is, for instance, the articulation of pregnant people as vulnerable. So, saying, look, implying that they don't have the capacity to make decisions about their body as soon as they're pregnant. The notion that one has to protect a fetus against the decisions of a pregnant person it's going to be its mother, right? Sort of the anxieties around maternal fetal conflict, which I think are overwrought, that are very, very gendered. So absolutely, I think there's a force of gender here, and I think that's both part of what has made it so hard, but also part of what has made it so interesting over time, because there's always new ways to sort of think about it and to get at it, if you will.
Great, thank you.
Thanks. So the two questions that have been put up there, I think both good questions as well. How can researchers mitigate the risk of fetal anomaly in pregnant participants in clinical trials which test drugs with unknown teratogenic effect? And the second one is, what new discoveries have been made recently in research involving pregnant women that could help improve the health of mothers and babies worldwide? If you can answer all that in 4 minutes, that's awesome. But we have time for some closing comments. But those are both big ones, so I'll turn it over.
Yeah, well, so I think these are all like really great questions, and I don't think I can answer them in 2 minutes. But so I think the first thing to know is that when we are thinking about involving pregnant people in biomedical research, there are requirements that certain animal studies be done before they are included, right? And so many times those animal studies are delayed because they are expensive, and there are financial incentives not to do those studies until you're fairly sure that you're going to get close to approval. But if you don't do those studies, then you will exclude pregnant people from biomedical research, but there's still going to be incident pregnancies on studies, right? So many in the HIV research community have pushed very hard to get those studies done earlier. There was a push to get those studies done earlier in the COVID context. So I think, it's necessary to get the pregnant people in the studies. And then what has to be done is that you have to monitor the data after the fact. So our studies of teratogens, I mean, according to one account, it takes 27 years from the time of approval to the time that we can say for sure whether the drug has risk for the fetus or not. So we can do much better both in the context of clinical studies and in the post-marketing situation, for instance, giving more authority to regulatory bodies to require that post-marketing studies be done. Again, something we could talk about for a really long time, but there is a lot that I would call low-hanging fruit. Studies that have been made recently in research involving pregnant women that could help improve the health. Well, I think there's been a really important push around understanding the use of preventives, HIV preventives in pregnancy. So again, this was an area where when PrEP was first being evaluated, even though we had a lot of reason to think that PrEP was going to be safe in pregnancy, a lot of reason to think that this was going to be used widely in pregnancy. Pregnant people were left out of those early PrEP trials. And we have since learned a lot about PrEP, and some of the newer PrEP modalities are under study right now. And I think, if we can figure out how to prevent HIV in pregnancy, we will do much better at preventing vertical transmission, because we know that when you get HIV in pregnancy, your risk of transmission goes way up. So I think the prevention, the HIV prevention area is an extremely exciting area for pregnant people. But there's a lot of exciting areas underway. But I'm really looking forward to seeing what's being done in PrEP. And in fact, the study that I didn't talk about called Purpose is allowing people to enroll without contraception, and if they get pregnant, they can stay on the study. So really a transformative approach.
Great. Well, that was outstanding. And thanks for addressing those questions, for sharing your thoughts with us. The recording will be available within a week or so. If everyone could still remember, as you leave the webinar today, an exit survey will pop up. Please go ahead and fill that out. As I mentioned earlier, I would love your input. So thanks, everyone, and have a good day or good evening, depending on where you are.
Thanks.